Okay, we'll go ahead and get started as folks jump on. But for the sake of time, we will go ahead and begin. Hi, everyone. Thank you all for being here for another webinar that we are putting together. This one is in collaboration with the Utah Cancer Coalition, so we're happy to have them on board today and talk about genetic cancer screening and risk and prevention here. So thank you all for being here to go through our agenda for today. So we are going to start off with some words from the Utah Cancer Coalition, Ali, who is part of the screening work group. Then we will transition over to Sam Beck, who is a genetic counselor for oncology, who's going to talk about understanding genetic cancer risk. Then we have Dr. Vera Kazakova, who's going to give us her perspective of genetic cancer screening from the provider perspective. And then we also have a patient, Cassidy Black, who's going to talk to us about her experience and her journey through genetic testing and how that has impacted her life. And then we are going to save questions to the end. So as you have questions, feel free to write them down or jot them down, and then we'll have a few minutes at the end for questions and then our post-webinar poll. But before we get started, for those who are new here or may have not participated in one of our webinars before, this is put on through the Mountain West Cancer Collaborative through Huntsman Cancer Institute. So we serve the Mountain West. Our services expand to Idaho, Montana, Nevada, and Wyoming, in addition to Utah. And we are the only designated National Cancer Comprehensive Cancer Center in the region, and we serve about 17% of the US land mass. So with that, our office has the mission to collaborate with partners, patients, advocates, clinicians, researchers, and students throughout the Mountain West to address those cancer-related challenges. Again, we serve these 5 states, and our programs really focus on building partnerships with community-based organizations, enhancing community awareness and education, improving access to care, and driving long-term data-driven solutions. And again, one of our really core pillars is partnering with communities, being the Office of Community Outreach and Engagement. So we really try to partner and do this work with our community folks throughout the 5-state region and beyond. And that is done through listening to community voices, building trust, and supporting community-led approaches to the work that we do. And again, if you are new here or are not part of our Mountain West Cancer Collaborative, we invite you to join. Again, we have these webinars quarterly that have different topics that we chat about. We have our newsletter that goes out every month with different cancer-related and community-related events, engagement opportunities, and other happenings throughout the Mountain West. And then we have ad hoc groups as well that you're welcome to participate in. So if you aren't part of the collaborative, please join us. It is free, and anyone is invited to join. And then a few of our objectives for today. So we're going to talk about the relationship between family history and cancer risk, hoping to recognize when genetic counseling and testing may be appropriate based on our personal and family history, and then identify resources and referral pathways to access genetic cancer screening services. And again, this webinar is in collaboration with the Utah Cancer Coalition. So we have Ali here, who is the Associate Director for State Partnerships at the American Cancer Society, and then the Access to Healthcare Work Group Chair with the Utah Cancer Coalition, who's here to talk about the screening work group and a little bit more about the work that they do. So just to read Ali's bio real quick. Allie is a public health leader with the American Cancer Society who is passionate about building partnerships that improve lives and strengthen communities. She has worked in multiple states during her nearly two-decade career with a special passion for rural health. Outside of work, Allie's leadership skills are put to the test by her 6-month-old daughter Barrett, Royal, the anxiety-ridden Doberman mix, and Miss Kitty, the self-appointed CEO of the Household Chaos, who you may see here. So, Allie, I will turn it over to you.
Thanks, Leslie. Yes, Miss Kitty is sitting in my lap right now. So, always all the fun with her. So, thanks for having us. I'm just going to real briefly talk a little bit about the Utah Cancer Coalition and then share a little bit about our screening work group that worked with Leslie and team to put this webinar together. So, the Utah Cancer Coalition, for those of you that don't know, is the statewide cancer coalition in Utah focusing on implementing the state's cancer plan. So we have 4 different work groups as a part of the coalition, a data work group, a prevention work group, the screening work group, of course, and then a survivorship work group. So we do all sorts of work across the cancer continuum and convene quarterly to learn more about what's happening in Utah. So next slide. So here are a few things that the screening work group is planning to work on in the upcoming fiscal year that'll start next month. So we work closely with the Utah Breast and Cervical Cancer Screening Program. Um, they are located at the Department of Health and Human Services, which also has the Comprehensive Cancer Control Program that helps to lead the coalition. So a lot of synergy there. Similarly to this webinar, we are hoping to provide 2 webinars focused on cancer screening for providers and healthcare professionals. So we are always looking for partners and topic ideas for those. So certainly if you have thoughts on things that you would like to see or learn more about, let us know. Our friends at Huntsman Cancer Institute also have created a cancer training module for community health workers. And so we're looking for ways that we can help to support the module and to increase the number of community health workers that take the training. From an advocacy standpoint, we have Komen very involved in our work group, and they are working at the state legislature to advocate for insurance coverage for breast cancer diagnostic services. So once someone has a mammogram, if they require any follow-up, that's not always covered by insurance. So we're really working to increase the out-of-pocket cost for that. Some of you may have heard about self-collection for primary HPV testing. So we want to continue to promote that. We know that this can certainly increase cervical cancer screening and help in many of our rural and frontier areas that might not have access. We also want to promote and support implementation of flu fit clinics, which couples the flu vaccine with the stool-based test for colorectal cancer screening. So the flu vaccine should be done every year, and your fit test should be done every year. So there's a lot of evidence that by doing both of these tests at the same time, we can get better adherence to both. And then we know in Utah that prostate cancer is higher than the national average. So we want to really start conversations around how we can promote best practices and increase awareness for high-risk groups. So that is just a little bit of a preview of some of the things we're working on. So you can go to the next slide, Leslie. So if any of these things interest you, or if you're just interested in learning more about the Cancer Coalition in general, this is a QR code that can get you signed up for the email list, give you an opportunity to join any of the work groups. So if you have a particular passion for prevention or survivorship or really love data, it gives you an opportunity to sign up for those groups as well. So Danielle, who helps to lead the coalition's email is listed here, or you can reach out to me too. So thanks for giving us a chance to just talk a little bit about our work.
Awesome. Thank you so much, Allie, and thank you to the Utah Cancer Coalition for being here with us today and your partnership in this webinar, and for talking to us about screening and the role that it plays in cancer prevention. Kind of to move things along to learn more about not only screening but genetic cancer risk. We're going to start with one of our presenters, Sam Beck. To learn more about Sam real quick, Sam is a board certified oncology genetic counselor with a master's degree in genetic counseling from the University of Utah and a bachelor's degree in biotechnology and biology from Utah Valley University. She has specialized training in hereditary cancer risk assessment and works in the Family Cancer Assessment Clinic and High Risk GI Genetics Clinic. Her clinical focus includes pancreatic cancer, Lynch syndrome, polyposis syndromes such as FAP, JPS, and PJS, and other hereditary cancer syndromes. So SAM provides comprehensive risk evaluation, genetic testing coordination, and counseling to support informed care and cancer management for individuals and families. So Sam, thank you for being here with us today, and we're excited to learn more about your work.
Yeah, thank you. So today I'm really going to be kind of describing how we can understand more of our genetic cancer risk. And you can go to the next slide. And so I'm going to be reviewing the relationship between cancer and genetics, and I'll discuss the importance of family history in cancer prevention. And then we're going to assess key red flags of hereditary cancer risk in a family history, and then explain the genetic testing process in the frame of common hereditary cancer syndromes. And these are just going to be a few examples of all of the possible different hereditary cancer syndromes that exist. You can go to the next slide. So a little bit of a genetics background is, in our body, we are made up of all of these cells. We have new skin cells, new hair cells. We're basically making replications of our body all the time. And these are through cells, which are really the building blocks of our body. And in these cells, we have chromosomes, which is really just long strands of DNA. So you get 23 pairs from your mom, 23 pairs, or 23 from your dad. So you have a total of 23 pairs total, so 46 chromosomes. And there's, these long strands of DNA that really just carry the genetic instructions. So these are the instruction manual of who you are, and that's through these genes. There's about 20,000 genes in our body, and basically they make up who we are. And when we have genetic mutations, this is when people are referring to changes in the DNA or these genes. You can go to the next slide. And so DNA changes is actually what give us genetic variation. And so DNA changes, you might hear them as mutations or variants, but they happen every generation. And so we have about 60 new DNA changes or mutations every generation. And they're really basically what creates the normal genetic diversity. So brown eyes, blue eyes, green eyes, all of these different, diversities. And they can be benign, like different eye colors, or they can be disease causing, like inherited cancer risk. And we have specific ways that we classify the DNA changes. And this is through a process called variant classification. And there's three main categories. The first one is normal, meaning that there's benign or likely benign findings, and the functionality of these DNA changes doesn't change at all. They're just different, like the different colored eyes. And then we have uncertain or variants of uncertain significance, meaning that we've seen a DNA change, but we don't know, is it just something rare that we don't often see in the general population, or is it disease causing? But we haven't seen it enough to understand what it means yet. And then we have disease causing, likely pathogenic or pathogenic, meaning that these DNA changes have occurred in the body and have limited the functionality of that specific, gene or segment of DNA. And so you have reduced or diminished functionality. You can go to the next slide. And this is really important because if we have reduced or diminished, gene function, then this can impact something that's called the cell cycle. And cell cycle is really just cell division. That is how our cells are growing and reproducing. It often occurs during development, but like I mentioned, new skin cells, new hair cells, it replaces older damaged cells. And so even if we're being exposed to DNA damage, cell division is going to, fix and happen, again, so we can have just regular functioning cells in our body. And there's these checkpoints that ensure that the cells are actually dividing accurately. But cancer begins when we have a single cell that gains a growth promoting mutation. So there's a DNA change that really now these cells have become abnormal. And so now they're able to divide uncontrollably. You can go to the next slide. And so what we know is that cancer is due to genetic mutations that are really controlling the way that cells are growing and multiplying. And so abnormal cells are growing uncontrollably. And most of these genetic changes are actually happening over someone's lifetime, but some of these can be inherited. And so, aging, lifestyle, and the environment, these are all things that can cause genetic mutations. And cancer-related genetic mutations that we often hear about are, radiation, UV exposure, mutations from just cells dividing, and then also an inherited type of mutation that can happen. And so all cancer is genetic, but not all cancer is hereditary. You can go to the next slide. So mutations, there's two kind of main categories. There's inherited and then there's somatic. So inherited is what we consider germline or at birth. And these are mutations that can be passed down from generations. And so there's a 50-50 chance that if you have an inherited mutation, you're going to pass that on to your children. And so this is going to be a mutation that's occurring in all of the cells of your body. They have the same type of the inherited mutation. And so this is DNA you're born with, so it's not going to change over your lifetime. But somatic mutations, these are acquired mutations. And so these have been mutations or DNA changes that have happened after birth. And so this is where we're seeing tumor formations. And it's due to these mutations of DNA from abnormal or cancerous cells. And so it can't be inherited. And usually we see it in just kind of the tumor or one specific location. Okay, next slide. And inherited cancers happen about 5 to 10% of all of the time, of all cancers that we're seeing. And it's really important to know because basically if we know the difference between someone getting a cancer diagnosis and knowing is that inherited or acquired, we kind of know the starting point of someone's cancer risk because if someone has a germline mutation, their first mutation is inherited. And so then technically their starting point is a little bit higher of a cancer risk than the general population because they don't need as many other DNA changes or DNA mutations to cause that malignant cell, cause that uncontrollable growth, and lead to a cancer diagnosis. But about 70 to 80% of all cancers, we have just regular normal functioning cells, and then we're acquiring all of the mutations to a cancerous cell to then leading to a cancer diagnosis. And so it's really important for us to kind of understand the difference between cancers being inherited or not. And next slide. So in short, somatic is a tumor-specific mutation, and these mutations are acquired. And what they do is they help us guide treatment decisions. So we want to know the type of somatic mutations that have happened because then it can help inform our diagnosis and prognosis and even give us options for eligibility of clinical trials. But germline mutations are inherited mutations, and we want to know these type of mutations because it helps us understand risk for you and your family, and it guides prevention or early detection, and then helps clarify the most appropriate screening recommendations for you and your family, and really hopes to increase survival rate. So somatic mutations are when we see a tumor or a cancer diagnosis. Germline mutations, someone can be diagnosed with cancer, but they can also be a healthy individual. Okay, and next slide. And so we want to be able to identify inherited cancer risk. And, the first step of doing that is meeting with a genetic counselor, and you can do that in person or you can do it virtually. So then if we do that, we want to do a family history assessment. And we do that with a tool called a pedigree, or just really a family history that's kind of almost in an image format. And so this is going to help guide recommendations like screening recommendations. Do we even recommend genetic testing for you and your family? And then are there any prevention strategies that we can do or recommend for you and your family to kind of, prevent or detect cancer earlier? And so, if you can see this image, on the top right, it shows that a circle is for females and a square is for males. And then this is what we call a multi-generational pedigree. And so there's grandparents at the top, and then your parents, and then in red is the patient where there's a little bit of an arrow, and then that purple are the children. And so what we're seeing in this is anytime there's a shaded in circle or square, that's someone having a diagnosis. And so the box in red is our patient is a 60-year-old male who was diagnosed with breast cancer. And then we can also see that they had a grandparent who had prostate cancer at 45. So that's just an example of how we would read that. Okay, next slide. And so case one, we have a pedigree here, and highlighted in bold is our patient Terry, who's a 39-year-old male who was assigned male at birth, but came in having abdominal pain, blood in his stool, and some changes to bowel movements, which ultimately led us to a colon cancer diagnosis at 39. But if we're seeing and we're looking around the rest of his family, we're seeing that on his mom's side, he has endometrial cancer in an aunt, prostate cancer in an uncle, and then a grandfather with colon cancer. And so we're seeing multiple generations with all of these different types of cancers. Okay, next slide. And so when we're looking at a family history, we're really using this tool to look for any red flags for a hereditary cancer syndrome. And so in the family history, we're looking at cancers in multiple generations. Are there 3 or more people who've been diagnosed with a cancer? Do they have the same type of cancer, like multiple breast cancers or multiple colon cancers? Or are they related types where we see breast and ovarian cancer go together, or colon and uterine cancer go together? Or was anyone diagnosed at younger ages under 50 with a cancer diagnosis? And then we're also thinking, is there a more aggressive or rare type of cancer like pancreatic, ovarian, endometrial, or like we saw earlier, a male with breast cancer, or someone having breast cancer in both of their breasts, or even a metastatic prostate cancer? And then, we're looking, is our patient, did they have a cancer diagnosis under 50, or do they even have multiple primary cancers, like someone with 3 or more, melanomas diagnosed? And then also the ancestry, is there any Ashkenazi Jewish ancestry or any kind of, suspicious ancestry that matches with that type of cancer? Or do we even know, is there an inherited mutation already going around the family? Next slide. And so for this case, we're seeing 3 or more people diagnosed with cancers in multiple generations. So we have the grandfather, the uncle, the aunt, and our patient Terry. And then we're seeing at least 1 rare cancer. So there's a maternal aunt with endometrial cancer diagnosis. And then a colon cancer at 39, so under 50. And then someone having the same type of cancer. So there's 2 colon cancers in the same family history. Next slide. And so we're really suspicious that there's a hereditary cancer syndrome going on. And so we want to offer this patient germline genetic testing. And there's lots of benefits and harms when we're thinking about doing genetic testing. Some of the benefits, though, we can learn about your hereditary cancer risk. Maybe is there an explanation why you got this cancer diagnosis? Or if there's no cancer diagnosis, can we be preventative with medications, surgeries, or earlier, more often types of screenings? And then family members can also learn their cancer risks through a process that's called cascade testing, where we're able to test all of the family members and help identify if there's an inherited cancer risk. And so really the goal is putting these patients in a category of previvor instead of survivor if they've never had a cancer diagnosis. But some of the harms, you can't unlearn this information. And sometimes, the management guidelines or what's the best approach can be really difficult because each patient, we're working in the rare world. And so each patient might have a polyp that's growing in a weird location and no one's ever worked with that before, or, we don't have clear guidelines on what to do. And so it can be really stressful for people. And then there can also be discrimination with life insurance and long-term disability. And then there can obviously be possible shifts in family dynamics, right? This is a family thing with an inherited mutation. And if you're not talking with family members, how do you tell everyone that they might also have, an inherited cancer risk? And that can be a really big stressor for a lot of people. And then, like we mentioned earlier, that we can have these uncertain results, and those can come with unclear guidelines, and so they might cause psychosocial distress. Next slide. And so when we're thinking about genetic testing, we're thinking about what type of results you can get. And it does go along with the variant classification of these DNA changes that I had mentioned earlier. And so we have those three results, the positive, negative, or uncertain. Most of the time, if you're doing genetic testing, you're going to see a report. It will say either positive or uncertain, and it's assumed that they're negative. Okay, so if you have a positive, a likely pathogenic or pathogenic variant, that means you were born with an increased risk of developing cancer. So it's not 100% chance you were going to get cancer, just an increased risk. And because of that increased risk, we want to do additional screening. So sometimes that looks like multiple doctor's appointments, getting EGDs, getting colonoscopies often. But you don't have to just navigate that on your own. We have a high-risk genetics clinic where you can follow up with just usually having an annual appointment. And so patients who have an inherited or positive result kind of have someone in their corner to help with all of the guidelines and all of the research and kind of keeping them current. And then we would also recommend family members to do genetic testing as well. But if you have a negative result, but still a family history of cancer, there's possibly environmental factors that we don't know, or maybe there's a lack of gene discovery. And so we don't want to just say that you don't have cancer risk. And so we'll want to make recommendations based off of what we're seeing in your family history. Sometimes that can look like negative genetic testing, but you have a suspicious family history of breast cancer in the family. And so are there more often or different kinds of breast screening that we can do for you based off of just what we're seeing in the family? And then there's the uncertain or variant of uncertain significance, where we have kind of unclear management. But these results are often negative. They usually are kind of something like green eyes, where it's just a DNA change that's benign, but you don't often see it. And so we'll still use family history to make our recommendations, but just the unknown can cause, again, some psychosocial distress. Next slide. And so with this patient, we're going to offer germline genetic testing, and here are some of the logistics. So, there's multiple different ways that we can collect the sample. That's through blood, saliva, or a cheek swab. And let's say, someone wants to do a blood draw, but they're not close to a Huntsman facility. We can actually set it up as a mobile phlebotomy where someone can come to your house and do a blood draw. So for everyone who's in states outside of Utah, this is an option that we offer to a lot of our patients. And there's multiple different labs. So depending on your history, your insurance, kind of coverage and everything, we're able to order through the most appropriate lab based off of what we're seeing with your history. And cost is actually, it used to be thousands of dollars to do the genetic testing, but now it is pretty accessible and affordable, where most of the time we can use insurance to bill. And so many people pay around $30 to $60 for the genetic testing. But let's say if you have a high deductible or you don't have insurance, there's self-pay pricing where it's around like $250 for people to get the genetic testing done. And even if 250 seems like a lot, then there's patient assistance programs where you just kind of self-report your household income, medical debts, and most of the time we can get the cost down to $0. Next slide. And so with Terry, we did germline genetic testing through Ambry Genetics using a blood sample. And what we're seeing here is that we found an MSH6 pathogenic mutation. And what you can see is that C dot is just showing us specifically on that strand of DNA or that segment of DNA where the DNA change is. But we've determined that this changes functionality in this gene. And so this patient was born with an inherited MSH6 gene mutation and now has a diagnosis of Lynch syndrome. So they were born with an increased risk to develop colorectal cancer, and then they actually did end up getting a colon cancer diagnosis. Next slide. And so a little bit more about Lynch syndrome is there's a lot of different cancers that can be associated with Lynch syndrome, but the highest cancer risks are often colorectal cancer and uterine and possibly ovarian cancer. And so because of those main risks, we want to start colonoscopies and EGDs starting in their 20s, and then we'll do them every 1 to 3 years, which is drastically different from the general population where colonoscopies are happening at 45 and we're doing them every 5 to 10 years. But with the uterus and with the endometrium, we can't really screen for those cancers. And so there's no way that we can really detect these cancers early. So the goal is prevention or early detection. And so we recommend removing those organs to prevent that cancer. And that can be very specific and tailored to your family plan and your personal history of personal and family history of cancers in the uterus as well. And so we'll look at the family history to then determine if there's other cancer screenings that you might be recommended to have. Next slide. And so in summary for this patient, it's a 39-year-old patient named Terry who ended up having colon cancer kind of a younger age. We found out that he did in fact inherit an MSH6 pathogenic mutation. And so now we want to recommend genetic testing to all of the other family members. And so he has 2 daughters that are 5 and 7, but they're not going to have a cancer risk until they're in their 20s. At least in their 20s. And so we wouldn't really recommend to do genetic testing until they're at least 18 years or older. And that's for a number of reasons. One, we want them to be able to be mature enough to understand the information to then actually decide if they want to know this information for themselves. And then, if we test them and they don't have cancer risk, it ends up causing a little bit more harm because they don't have really any control of doing anything, and so it can just be a lot more stressful and can cause a lot of psychosocial distress. And then obviously we're thinking about the mom side having all of the cancers, so we definitely would want to start with the mom side of genetic testing, but any family member who's close to Terry is able to do genetic testing, and oftentimes for free for a short amount of time. So we're seeing this Lynch syndrome diagnosis, which means anyone else in the family history who tests positive for the same MSH6 pathogenic mutation will be recommended to have additional screening and management because there are additional cancer risks that are present for them. And you're not alone in this, and we'll have that high-risk clinic that you'll be able to see. And so you can have these annual discussions where we're keeping up with the current literature, we're doing the research on these specific mutations, so then we can really give you the best care that's current with what's going on and what we know about today in the research world. Next slide. So here we have another case. Here's our patient. You can kind of see on the lower left in circle, and there's the arrow. That's Maria. She's a 30-year-old assigned female at birth patient who does not have cancer, but her mother was diagnosed with ovarian cancer at 45 and unfortunately passed away from that. And if we're looking at other family members, we're seeing a maternal aunt with pancreatic cancer, a maternal grandmother with breast cancer at 42, and then another cousin with breast cancer in her 40s. Next slide. And so there's 3 or more people that have been diagnosed with cancers in multiple generations. So the grandmother, mother, aunt, and cousin. And then they're rare cancers that we're seeing. So ovarian and pancreatic cancer. And then in the family, they're being diagnosed pretty young. And we're seeing at least 2 people with breast cancer in the family. Next slide. And so we did genetic testing for Maria, and we saw that she has a BRCA1 pathogenic mutation and was born with an inherited BRCA1 gene mutation, which leads to a diagnosis of hereditary breast and ovarian cancer syndrome. So she was born with an increased risk to develop breast, ovarian, and pancreatic cancer. Next slide. And so HBOC, or hereditary breast and ovarian cancer with BRCA1, means that we're going to offer earlier and more frequent breast screenings in the form of an MRI and a mammogram. And then if there's males, they can also have a prostate cancer risk. So we're going to offer prostate cancer blood draws a little bit earlier. And then just like Lynch syndrome, we do recommend organ removals of the ovaries and fallopian tubes to reduce that ovarian cancer risk. And then pancreatic cancer screening is, can be screened in 2 different modalities, but we only recommend that if there's a family history of pancreatic cancer. Okay, next. And so in summary, 30-year-old Maria had a mother who passed away from ovarian cancer, and she inherited this BRCA1 pathogenic mutation. And so she has a brother, so we'd immediately recommend genetic testing for the brother because there's a 50-50 chance he might also have a prostate and pancreatic cancer risk. And but we might want to start with the mother side of the family first. And then if anyone has the hereditary breast and ovarian cancer syndrome with the BRCA1, then we're going to want to do additional screening and management for all of those individuals who test positive because those cancer risks are present. And so there's high risk, again, clinical annual discussions that we can have. But Maria doesn't have children yet. And if she wants to have children, there's a lot of IVF options available where we even have some grants where she can do IVF with, hopefully some financial support. And before she would ever, maybe need to see if her children have the BRCA1 mutation or not, you can actually test the embryos to see if they have that. Next slide. So, there's a lot of consideration, but ultimately, is genetic testing right for you? And there's a lot of things to consider. If you're just curious and you want to know, I think about if you're ready for this information. Would you be ready to do more screenings? Would you have any of these procedures or not? If there's any uncertainty, what would you do? And, how do you think other family members would handle this? And then obviously we went over these red flags, but if there's anything that seems suspicious, a lot of cancers, rare, younger ages, something to think about that maybe genetic testing could be good for you. Next slide. And so if you are interested in doing genetic testing through our Family Cancer Assessment Clinic, there's a scheduling phone number. You can also look us up on the Huntsman's webpage, but you can even self-refer. And you don't need to make an appointment that's in person. We have a lot of telehealth options. So there's video or just even telephone options that you can do. So you don't need a referral from a provider to be seen in our clinic. Next slide. And then here's some resources. If you're looking, if you do have a positive mutation, some of these are great resources to kind of utilize for you and your family. Okay. Thank you. I know that was a lot of information. If we don't have time for questions, you're always welcome to email me for any of these questions.
Awesome. Thank you so much, Sam, for all of this wonderful information and walking us through the relationship between cancer and genetics and family history and cancer prevention. This was all great information, and it was awesome to see those case examples as well, to see your work in action. So to kind of shift from our now baseline knowledge of genetic cancer risk, we're going to shift to the clinical approach with Dr. Vera Kozakova. So Dr. Kozakova is an oncologist at Huntsman Cancer Institute and an assistant professor in the Department of Internal Medicine at the University of Utah. And she is going to be here today to talk about how healthcare providers can use family history and genetic information to guide screening, prevention, and referral decisions, and then address some of the most common questions that patients ask about genetic testing. So, Dr. Kozakova, we're happy to have you here today.
Hi, everyone. I'm also very happy to be here today. Thank you so much for giving me this opportunity. And as Leslie mentioned, I'm going to talk about kind of perspective on genetic testing and how it can really help us to make the right recommendations for people and hopefully help to support somebody's health before cancer diagnosis and recommend appropriate screening and prevention options. My role, I'm actually a breast medical oncologist, so I mostly see people with breast cancer, and I also see people who are at increased risk for breast cancer, frequently because of genetic mutations. So I think that I will focus a little bit more on breast cancer predisposition, but of course it applies for different cancers as well. And can we do next slide? Next. So first, we're going to review family history impact on decisions about genetic testing and cancer screening and prevention. And after that, we're going to discuss common questions and misconceptions about genetic testing. And I'll try to answer some more common questions about this. I think we can go to the next slide. So we all agree that family history is important, but at the same time, family history can be missed. Let's look into some reasons why family history can be missed and not necessarily collected or acted on during a visit. First of all, you probably notice that most of your doctor visits are quite busy, and there are multiple different topics that are being discussed. So sometimes family history is not fully addressed during a very busy visit. At the same time, it would still be important, again, to consider incorporating family history discussion, at least into your preventatives like wellness visits, physicals. Also, a very common situation that people may not know exact diagnosis. And for us, it is very important to really understand better what is exact family history cancer diagnosis to make a right decision about the next steps. And the more details you're able to get, the better. We're going to talk about this more. Also, families may not discuss cancer openly, especially it was very prevalent in the past. And many people just know that there was some cancer diagnosis, but they know that, for example, it was concealed in the family and people were not open about that because there was some stigma about the cancer diagnosis, or people just didn't want to burden their loved ones with their health issues. Also, some families are separated and relatives may live very far away. There is no close contact. And of course, another unfortunate reason why family history can be missed is that there may be limited access to care where the person lives. Let's go to next slide. So what can help to get accurate family history? The most important part is, I think, preparation prior to the visit with your doctor. It is very important to talk to family members prior to that visit to get information about cancer family history and potentially other family history that you want to bring up. And try to write down all the information that is shared, including cancer types and ages at diagnosis if possible. And both cancer type and age is very important and can lead, for example, for better insurance coverage for the testing or actually a referral for testing. Cancer type is also important. For example, if we're talking about the breast cancer, if somebody is diagnosed with triple negative breast cancer, we kind of always test, and it's one type of breast cancer. And we would consider testing even if the person was diagnosed much later in their life. But for some types of breast cancer, if the person is diagnosed much later in their life, we not always discuss genetic counseling referral and genetic testing, because unfortunately breast cancer is very common among women, people with breast tissue, and it is at this time, we're not testing absolutely everyone with a breast cancer diagnosis in the family. We're more looking for those, again, red flags like early age and diagnosis, especially younger than 50, but we're now considering younger than 65 in certain situations as well, or several breast cancers on one side of the family. So the more details you can include, the better it is. Same with, for example, thyroid cancer. Certain thyroid cancers, like medullary thyroid cancer, tells us that we need to test right away. Other types may not lead to jumping into genetic testing. So the more details you can include, the better it is for us. Then, of course, it's important to update your doctors and clinicians about changes in the family history. So if there's a change in your family history, for example, and you family member, unfortunately, is diagnosed with cancer, it would be important to notify your clinician about this, especially your primary care doctor. And please bring up the concerns, even if not specifically asked to. Again, we discussed that visits can be busy, but it is important to bring up, like, come prepared, share your family history, and ask important questions, including the questions like, is my family history concerning? Is it reasonable to get genetic testing based on this? Is my risk elevated? Is there any change in screening recommendations based on my family history? Next slide. So how do we usually collect family history? In our clinic, we usually do it during the visit and also through a pre-visit questionnaire, which again really helps us to miss less information during our visits. We usually try to collect information about 3 generations, as you see here. So for example, if we imagine that this circle represents a woman who comes to see us, and this is kind of the common way how we document family history by doing this type of a family tree. So for example, this 51 years old woman comes to see us, and she shares with us information about the 3 generations. She tells us her sister was diagnosed at age 47 with breast cancer. Your brother does not have any family history or does not have any history of breast cancer or any other cancer. And then she shares that her father was diagnosed with prostate cancer at age 72, and that her father's sister, her aunt, had ovarian cancer at age 56. So again, here we documented the ages of diagnosis and then kinds of cancer, which is very important for us. If this person is able to bring us information about stages of cancer, that would be also helpful. Again, is it always possible? Absolutely not. If it's possible, that's helpful. Because, for example, for prostate cancer, if it is a very early low-risk prostate cancer by itself, no other family history of cancer, it does not necessarily trigger genetic testing. If it's a more advanced prostate cancer, especially metastatic prostate cancer, high risk, we would consider genetic testing, even based on this father's history as well. And let's think here who can be considered for genetic testing based on this information. So, of course, the person in front of us, we always discuss and offer genetic testing to them. So if I'm seeing today this 51-year-old lady, I'm going to discuss that, yes, she does meet indications for genetic testing. I would recommend this for her. But also it would be extremely helpful to get information about her sister, because she does carry the cancer diagnosis, and it would be important to know, was this cancer diagnosis linked to a genetic mutation? And it can make a difference not only for the sister, but for the person in front of me, this 51-year-old lady. Why does it make a difference? For example, the sister who has breast cancer is diagnosed with a genetic predisposition. Let's imagine that she has a BRCA1 mutation. But our patient, the 51-year-old lady, does not have that mutation. That means that her sister's results not necessarily apply to her. We are not that worried about her breast cancer risk. We still need to evaluate, consider it, but the fact that her sister was diagnosed at 47 does not directly apply to her. For example, she does not have that mutation. So testing affected family members is very important, and of course, very important to test the person who is in front of you. Let's go next. So actually, I was planning to discuss this information about who should be tested for this slide. The idea is the same. So who should be tested? Of course, we want to test it in individuals with a cancer diagnosis when possible, but testing of unaffected family members is also very helpful and informative. Next slide. So what happens after a concern is identified? So, for example, this lady, 51-year-old lady, came to us and shared that she has a history of prostate cancer in her father, of breast cancer in her sister. We would want to do a genetic counseling referral, or if we can go directly to genetic testing. Genetic counseling referral, as Sam mentioned, doesn't mean that the person is going to have tested, right? That's a discussion. It can be done virtually or in person. And during that discussion, frequently they go over again family history, address pros and cons of testing, and then they can order the test, but it's not mandatory. Sometimes people decide that that's not the right choice for them. At the same time, I think that it's a very, very helpful, and many people who we see in clinic really appreciate that opportunity to have a discussion with genetic counselors and consider genetic testing. Also, another part that is separate from genetic testing, even if the person decides not to proceed with genetic testing, family history still plays an important role in our risk assessment. And sometimes we can recommend additional screening or earlier screening or preventative strategies just based on family history alone. Next slide. So let's imagine that now we see a 35-year-old woman. She's very young. She is below the age when usually we consider doing screening for breast cancer, right? Typically, mammograms start around age 40. She's 35 at this time. And she shares with us during her visit that her mother was diagnosed with breast cancer at 45. So what would we discuss with her? Would we recommend genetic testing? Absolutely, because of her mother's very early diagnosis. But in addition to that, even prior to genetic testing, or if she, for example, decides that the genetic testing is not right for her, we would calculate her specific breast cancer risks. We have certain models. One of the common ones is called Tarek-Cusick. There's also Gale model. There are different other models that we can use to estimate somebody's breast cancer risk. And we can give information about 5-year risk, 10-year risk, lifetime risk. And depending on that risk, we can, for example, discuss adding MRI to mammograms. So right at this time, most women are recommended to go for annual mammograms. Here we would think for people at high risk, we would think about adding MRI to that mammogram. For this person, we would not wait until age 40 before starting screening. We would start screening now at age 35 because we usually start screening about 10 years earlier than the diagnosis of the earliest diagnosis in the family. So her mother was 45, so at 35 we want to start her screening. And depending on her risk calculations, if she's at very high risk, we would also discuss preventative strategies that some of them can focus on lifestyle, but some of them can focus on starting to take a pill. There are certain pills that people can take to decrease their risk of breast cancer if they're at high risk. Next slide. So if she's found to have BRCA1 mutation, then it changes her management even further. First of all, we would consider to start screening very early. For people with BRCA1, BRCA2 mutations, we start screening as early as age 25. That's why at this time it's recommended that every woman has assessment of their family history and breast cancer risk by age 25, because some of our interventions start extremely early. And definitely, unfortunately, we see in clinic people who were diagnosed prior to age 30. And luckily, some of them were diagnosed with small tumors thanks to screening, because they went through their genetic testing based on their family history. They found out that they have a high risk mutations. They started their screening and were unfortunately diagnosed with breast cancer. Can we go one slide before? And then. So we would also discuss with this person risk reduction, including surgery. We would consider certain medications. We will discuss with her surgery to remove ovaries because of the high risk for ovarian cancer. And as Sam mentioned before, we will definitely discuss reproductive and family planning options. Next slide. So now let's go quickly over some very common questions. So one of the questions is, will insurance discriminate against me based on genetic testing results? In general, there's a Genetic Information Non-Discrimination Act, GINA, that helps protect people from discrimination based on genetic information in health insurance and employment. However, these protections do not currently extend to life, disability, or long-term care insurance. So sometimes people, for example, want to make sure that they have life insurance prior to doing genetic testing. Next slide. Another common question, if I already have cancer, why genetic testing may be recommended? So genetic testing is very frequently done for people with cancer diagnosis. It can affect treatment decisions in certain situations. For example, we use medications like olaparib for people with breast cancer and BRCA mutations. Then it can impact future screening. And for example, we are going to recommend again MRIs and mammograms for breast cancer screening. And of course, it affects family members and what they do for their health. Next. Another common question is, I already did a 23andMe or different direct-to-consumer test, and it was negative. Is that enough? So it's a little bit more trickier question. Frequently, direct-to-consumer tests, including 23andMe, are more limited than the panels that genetic counselors use for their assessment. It looks into number of these mutations, variants, but not necessarily it is as comprehensive. So if a person had direct-to-consumer tests, I think that it may be a good discussion with their physician or genetic counselor if the test that they had was enough and comprehensive, because there are some direct-to-consumer tests that are quite comprehensive and can cover most of the important things that we're looking at. Or do we need to repeat a test? So if you had a direct-to-consumer test, at least talk to your physician or to your genetic counselor to discuss if that was enough. Next. And I think the last question that I prepared here, if I have a mutation, does it mean I'm going to get cancer? So as Sam has already mentioned, most inherited cancer mutations increase risk, but they don't guarantee cancer. So many people with hereditary cancer predisposition never develop cancer or die from cancer, especially when they have access to earlier screening and risk-reducing care. Next. And so my key takeaways is that family history is important to guide genetic testing as well as screening and preventative strategies. When possible, collect information about cancer diagnosis in the family with as much detail as it is possible for you. Collect ages and diagnoses prior to the visit. And finally, genetic counselors are a great resource for support regarding genetic testing. And Sam already mentioned contact information. I also put here some of the podcasts that we're doing. One is Huntsman podcast. The other podcast that we're doing with my colleague, genetic counselor Whitney, and my colleague, Dr. Colonna. We see patients together in clinic for people at increased risk for breast cancer. It's mostly targeted towards clinicians, but just wanted to share this resource. It's kind of our hobby and free time project. And thank you so much.
Awesome. Thank you so much, Dr. Kazakova. This is great information. I'll definitely be checking out the podcast and for answering some of these questions. I know some of the folks that join us today do work with communities who may not be familiar, and these are great questions to have answered for them to take back to their community members when talking about genetic testing. So thank you again for your time. Again, if you do have questions, we'll have some time at the end for both Sam and Dr. Kazakova to answer. So, moving forward with our last speaker, we've heard from Sam, who is a genetic counselor, who gave us that baseline understanding of genetic testing and how it happens, Dr. Kozakova from the provider perspective. And now we have an actual patient who has gone through this journey, who is here today to talk about what that looked like for her, and talk about some of the things that she felt and went through this journey. So I'm excited to welcome Cassidy Black. I'll read her bio real quick. Cassidy grew up in Alaska and later settled in Montana, where she attended college, got married, and started a family. She is a stay-at-home mom to her 2-year-old son. In 2019, Cassidy was diagnosed with a SMAD4 gene mutation, and since then has remained committed to keeping up with routine screenings, scopes, and medical appointments. Last year, she was diagnosed with a large complex mass in her stomach, which led her to seek specialized care at Huntsman Cancer Institute. So, welcome, Cassidy. We're excited to have you.
Hi everyone, thank you for having me. Like Leslie said, I was diagnosed with a SMAD4 gene mutation back in 2019. My younger sister started having mostly really bad stomach pain. And for months, my parents were trying to seek medical attention in Alaska and basically were told there's nothing wrong with her. We'll see in August, and it was February at this time. And long story short, ended up going to Seattle Children's. And she got a colonoscopy, and that's when they discovered that she had juvenile polyposis syndrome, which led to later getting genetic testing done. And then about 4 months into her medical journey, I also started to experience the same intense stomach pain, blood and stool, constipation, things of that nature. So that coupled with my sister getting her newer diagnosis was pretty easy for me to go and get a referral for a colonoscopy as well. And that's when they found 19 colon polyps, all of which were benign, thankfully. Um, Originally, for 3 generations, doctors thought that my family had Marfan syndrome, which is, from what I understand, a heart condition. They had no idea that it wasn't Marfan's and that there were other things to this genetic component. So we weren't being monitored for any of that. We would just go see a cardiologist every couple of years, and they'd say, "Okay, you look great. We'll see you in a few years." Um, so I was 20 years old when I found out about this disorder. SMAD4 causes juvenile polyposis syndrome and also HHT. I cannot pronounce the full version of that, but it causes um, issues with brain aneurysms and AVMs, so clusters of blood vessels and veins, which I also have as well in my lungs. But thankfully, they are small enough that they're not causing issues, and we're just keeping an eye on this for now. Um, Back in 2019, I got my first scope done. They said we'll see you again in 6 months because we didn't have enough time to get everything out. So I went back in February of 2020. Um, they did a colonoscopy and an endoscopy. They got, I believe, 5 more polyps out of my colon, and my stomach looked clear. So we started doing every year I'd go in for a colonoscopy, and every 2 years I would get an endoscopy done. And my stomach looked really great. I would just go in for scopes before I'd fly back to Montana for school for the year, and just that was just my summer routine was getting scopes done before college. And everything was benign. My stomach was clear. Everything was only in my colon. So I eventually, the summer after I got married, this was summer of 2022. I actually flew back to Alaska and did a colonoscopy there because I hadn't yet switched doctors to Montana. That following year, I actually got pregnant with my son. So I missed my scopes that summer because I was 6 to 9 months pregnant during that time. I got in for a colonoscopy that December here in Montana. I just went to a normal hospital. The GI doctor there kind of didn't quite know what to do with me. He's like, "What do you want me to do with the polyps if I find them?" And I was like, "Please remove them. Like, let's not leave them." Like, he just wasn't quite sure. You could tell he was just used to scoping people 45 plus. Everything looked clean, not a big deal. I then switched doctors because I just didn't feel super confident with that care. I also didn't get an endoscopy that time. And I believe the scope I had in summer of 2022, I did not have an endoscopy either. And then, so summer of 2022 to December 2023, I did not have an endoscopy done. So fast forward to last January of 2025, I go in for a colonoscopy with my new doctor. I tried the new prescription where you take 24 pills for your clean out. It did not work well for me. So I was told, hey, we're going to try this again. It was not successful for clean out. Come back in March. So I came back in March and they were like, oh, let's also do an endoscopy. It's been a while. So we did an endoscopy, a colonoscopy, and the day before I did a pill cam just to kind of check everything out. And that's when they found the mass in my stomach. I believe it was 47 millimeters. And it was right under my esophagus. So they were able to remove all of my colon polyps, but because I was at a small little clinic in Missoula, Montana, they weren't able to touch the mass in my stomach. So I'm used to going in, they remove things, they say, looks great, we'll see you in a year, wait for biopsies in 2 weeks. And this was a very different conversation. There's a very large mass and your stomach, we're not allowed to touch it. And there are no doctors or facilities here in Montana that can take your case. You have to go out of state to receive care. I'm oh, also your pancreas has a very large polyp on it too, and we need that to come out this week. So we're gonna send a referral to the hospital, and you're gonna have an appendectomy in the next 2 days. So you need to do another partial clean out for that just in case. So it was a very big whirlwind. I had an 18-month-old baby at home, and you just start thinking of all the scary things that could happen. Is it cancerous? If it is cancerous, has it spread? What does this mean for my family? And so I just kind of started spiraling mentally because I knew that if I would have just kept up with the endoscopies, I would have been fine, theoretically. So I was kind of kicking myself for that. So we started talking to a bunch of different doctors in Washington and Utah, trying to get into Mayo Clinic, and we finally decided that we would go to Huntsman. It was very easy to get in. The wait list was short, and my insurance, thankfully, at the time covered care there. And so we also had family that was within an hour away, and so we decided that that was probably our best place for care. Next slide, please. So then the question was stomach removal. Actually, that was our only option at the moment. It was we started with an advanced endoscopy, where they thought, hey, we can just go out and try and take the mass out and see what happens. That was a massive fail. They went in, because it was in right under my esophagus, they had to go down via endoscopy and then kind of turn around and go backwards, and it was very bloody and they couldn't see what they were doing. They would poke it and it would ooze. So they came out without doing anything because it just wasn't safe. And they went, okay, we can't do this. Let's get you into oncology. I believe they were able to take a very small section for diagnostic testing, and thankfully it came back benign. And oncology was like, thankfully it's benign. At least that part is. It's very large, so we can't promise that it's all benign, but it might buy us some time to make some decisions. So we were talking about a full stomach removal. I'm 25 years old. I had just turned 26. I have a baby at home and I'm thinking, I didn't even know yesterday that you could live without a stomach. And I'm like, if I have to live with a bag, like, what does this look like? What is my life going to become? But at the moment, it was live without a stomach or just let the mass go and see when it becomes cancerous. So my initial reaction was, okay, let's just take my stomach out because that'll at least buy me time with my family. So we decided with my oncologist that we would table the idea and she would go to tumor board and bring it up with other oncology surgeons because obviously her first idea was not to remove my stomach just because it is hard. It's a 6 month recovery. You eat nothing but liquids for 6 months while your stomach heals usually. And I'm 110 pounds. And so there was a lot of worry about how much weight I would lose during this process. And so we were trying all of these different protein shakes to see what I could stomach. And then we were trying to um, get me on a diet beforehand so that I could try and gain as much weight as possible in preparation for the surgery. Um, while this is all happening, one of my care team nurses who kind of talks with everybody on my care team at U of U went to the head of the advanced GI department and said, hey, look, this girl's 26. She's a young mom. I don't know if there's anything we can do, but I feel like there's got to be a step between where she's at of not touching it and stomach removal. Like, what if we just you figure something out and we'll try it, and then worst case scenario, we're back to stomach removal. And he said, okay, let me think about it, do some research. And he decided that we could try, if I was on board, to surgically go in and flip my stomach upside down so that with the endoscopy, there was a clear shot of my mass. So he could work um, normally and not have to go upside down and backwards and all of these things. So I was like, what the heck? If this is my option, I'd rather try this. And if it doesn't work, it doesn't work. We're no worse off than we were. And the worst case scenario of that experimental surgery was that they'd have to remove my stomach, which we were already there. So that didn't scare me as a risk. So I decided, let's try it. So we went and in September of last year, we went into this experimental surgery and they said if we can get half of this mass out, it's a success. They were able to get somewhere between 80 to 90% of my mass out during that surgery, which was a huge success. All of my biopsies came back benign, which was a miracle based on how it looked. Nobody, including my oncologist, thought it was going to be benign. Um, And it was just a crazy out of control polyp that just grew and grew and grew and turned into a mass. So that was huge. It took me about a week to recover just from the incisions. I did nothing in my body for 6 hours, and then I was able to do a clear liquid diet and then a liquid diet for another day, and then I was on like soft foods for a few days. Like the recovery was not bad at all. And then I went back in November, had another endoscopy where they chipped away at it. And then um this past May, on May 6th, I had another endoscopy where they went in and they were able to remove the rest of my mass. So I'm currently mass free, and they were able to get all of my other polyps out as well. So, next slide, please. So some of the barriers that we have encountered seeking care out of state has been a little bit difficult. Because my mass was benign, I was denied travel benefits through insurance. So usually when you have to travel so far, insurance will pay for your travel, whether it's covering gas or airline miles, hotel, food, any accommodations you might need. But because I wasn't cancerous, they denied me, saying that it wasn't necessary for me to seek this care. So between family helping us out with lodging, with food, everything was out of pocket from either my husband and I or family, which thankfully we had that support system that we did because we would be in some crazy debt right now with all of the trips that we've done and all of the week and a half long stays. Um, My insurance also decided that as of this year, U of U was no longer covered in network as it was last year. And so I spent a few months from January trying to call and get my endoscopy covered because otherwise it would be a $21,000 deductible before they would even step in to begin helping pay. Thankfully, they did end up deciding that it was medically necessary. Um, so that was really stressful because I knew I needed this care. I only wanted a view of you. They knew my case. I was well taken care of. Um, and I didn't want to try and get in with any other hospital when I had an incredible care team. Finances, my husband is self-employed. He's a barber. And last year we missed prom, we missed graduation, and we missed the beginning of back to school. As you can imagine, those three coupled with Christmas are the most busiest times. So that was stressful just trying to figure out where he needed to be. Of course, he wanted to be with us in Utah, but there was some times where he would have to go back to Dillon and work a little bit. So that was really stressful trying to go back and forth. Um, we also like childcare. What do you do with your 2-year-old? He's not allowed to come to the appointments, obviously. So where did we leave? And thankfully, we had family more than willing to step in and help. But for those who don't have that and they don't have the option to leave them at home with somebody, like I can't imagine the stress of that. I was stressed enough with the help that we had. So that was another barrier. And then just the unknown of what comes next. Is the surgery going to work? If I do have to get my stomach removed, what does that look like? Am I going to be able to keep up with my son and give him the quality of life that I thrive in and I want to give him? Are we going to have more children in the future? Is that a wise idea? So there was just a lot going on mentally. Um, but thankfully with the care team that we had, it felt more like we had someone holding our hands through the process. Um, which was amazing because this was unexplored territory. Like I said, we knew, okay, once a year scopes, you're in, you're out, see you next year. So it's been a crazy whirlwind of a year and a half of trying to get this mass out and trying to get me back to a healthy state. But we're here and I will never be missing an endoscopy again. So, um, yeah.
Thank you so much, Cassidy, and for sharing your journey and being with us here today. We're glad you're okay through all of this experience and all these barriers, and you're pulling through. So we're really happy for you. And thank you so much for being vulnerable and sharing your story with us. So with that, to kind of wrap up the next few minutes, we hope that this webinar here today really gave you more knowledge about genetic testing and family history, to then take back to the communities that you all work with and serve, to share more about what this is and how our community members can participate and also benefit from genetic testing. So with that, we're going to move into our post-webinar poll, who Ali is going to launch here in a few minutes. Just a few questions about this webinar today. At that time, if you do have any questions for any of the panelists, feel free to add those in the chat as you're filling out the poll, to kind of get things started as you're filling out that poll and asking your questions. I'll do our first question for any of our speakers. So that is, across the Mountain West, how can communities and healthcare organizations work together to help individuals understand their genetic cancer risk and access the resources, screening, and support services available to them? And that's for any of the speakers.
Are you okay to say that one more time?
Sure. So across the Mountain West, how can communities and healthcare organizations work together to help individuals understand their genetic cancer risk and access the resources, screening, and support services available to them?
I'll start and then everyone please fill in. I really think it's through community, and conversation. If everyone can just keep being engaged and if you hear people talk about things, keep conversation going because eventually they're going to end up at the right spot that they need to. And so really trying to highlight the community availability and always reach out to Huntsman because our genetic counseling team, we try to help our patients in weird and random ways. And so if you think there's something that doesn't make sense and no one's willing to do it, maybe our group will be able to try to figure something out. So I don't know if that fully answers the question, but don't hesitate to reach out to us always either too.
And Sam, does the Family Cancer Assessment Clinic provide services to folks outside of Utah?
Yeah, so we're licensed in all of the states around in the Intermountain West, and even if we're not, and a family member is, struggling to get connections, we can even help them find a genetic counselor near them, or we're able to, see them in different settings at different times. So yeah, definitely multiple states we can help.
I think I wanted to add to, like, I fully agree with Sam that I think spreading awareness that it's just important to think about the cancer risks from an early age and asking proactive questions to the doctors and the opportunity to just self-refer to the genetic counseling clinic. Their visits are free of charge, again, cover not only Utah but surrounding states as well, and can be a wonderful resource if a person has a question and needs guidance to what to do next. For people who are found to have a mutation predisposing to them higher cancer risk, they frequently provide quite specific recommendations, again, at least an outline what needs to be done in general that can be shared later with a primary care physician, for example. And also they can refer to those high-risk clinics when the doctors see people at increased risk for certain cancers to, again, hopefully provide care. And it doesn't have to be always following up in that clinic. It, again, can be a one-time visit when we discuss a plan and then share it with the primary care provider close to home and to implement.
Thank you so much. Any other questions? You can either come off mute or ask in the chat.
Leslie, we just have a general question in the Q&A about if the slides will be available. So you just want to mention
Sure. Yeah, so our webinars are all posted on the Huntsman Cancer Institute YouTube page. So it'll be available there, and then it'll also be sent out in our newsletter follow-up email as well.
Thank you.
Awesome. Well, if there are no other questions, thank you all for being here with us today. Again, the recording will be sent out. Thank you to our three speakers for sharing your experiences and your work that you do. And we hope you all have a good day. Thank you so much again.
Thank you so much for this opportunity. It was great to be here.
Yeah, likewise. Thank you.
Thank you.
Thank you.